Correct? Is it true? So, Mr. X, a 22-year-old, as a working in a shoe company, came from KV Kuppam, presented with complaints of intermittent high-grade fever with chills and rigor for past 5 months, associated with history of easy fatigability with loss of weight and appetite for 5 months. So he had no comorbidities. He had some in forehand. He had tattoos recently on 2 years back, and no history of any breathing difficulty, no history of chest pain palpitation, no history of any abdominal pain, no history of any oral ulcer or rash. Treatment wise, for symptomatic, so he went to nearby hospital whenever he has symptoms. On examination, he was moderately built with conscious oriented. On vitals, was hemodynamically stable. On general examination, it showed he had pallor, clubbing present. It was grade 3 with no peripheral signs of infective endocarditis or rheumatic heart disease. On systemic examination, cardiovascular examination shows tapping apical impulse felt at fifth intercostal space, half an inch medial to mid-clavicular line, and S1, S2 here with a loud P2 component. Here, high-pitched pansystolic murmur heard over the mitral area, which was radiated to axilla. Other systemic examination was normal. So, a 22-year-old gentleman presented with history of fever, loss of weight, appetite for 5 months. On examination, he had features of mitral regurgitation. So, what are the differences you consider? So, we consider most probably infective endocarditis or acute rheumatic fever, systemic lupus erythematosus, or atrial myxoma. So, we further evaluated. On initial workup, we had hemoglobin of 11, which shows microcytic hypochromic features, and total count of 10,300 with neutrophilic predominance. And ECG showed normal sinus rhythm with normal axis, no ST segment elevation or depressions. So on chest X-ray, there is no features of cardiomegaly. And so for echo, in echo it showed echogenic mobile mass of 30 mm cross 3 mm size over in the atrial view of the posterior mitral leaf left, associated with mitral regurgitation and no normal LV function with no regional wall mobility. So we sent 3 blood cultures. Till now, there is no growth so far. And for further differentials, we done ANA also, it was negative. We done BBVS, it was negative. And for iron shows iron deficiency anemia. So our diagnosis is culture negative infective endocarditis with mitral valve regurgitation, no, not on a failure, and iron deficiency anemia. So I'm here going to mainly talk about how important is the culture negative infective endocarditis and how to approach culture negative endocarditis. Is there any indications for yearly surgery in culture negative endocarditis, and is there anticoagulation will help to reduce the complications, embolic events in culture negative endocarditis? So this is an NEJM journal released from 2011. It is a retrospective study. Data was extracted from 1975 to 2000. In this way, in this journal, they analyzed totally 516 cases was infective endocarditis, out of which 63 cases were culture negative infective endocarditis. In 63 were 48 were native wall and 15 were prosthetic walls. Out of 63 culture negative endocarditis, they further evaluated and it shows 11 cases were pathologically proven by prosthetic wall endocarditis, and further 15 cases was serology was positive, and 4 cases were other side like a swab and a respiratory aspirate, it shows positive for other organisms. And other than 32 cases, the antibiotics was started before the blood culture drawn, so it came as a culture negative. Only truly culture negative was only the 6%. It is very, very low. So what are the most common organisms in culture negative? Mainly it was Coxiella burnetii, mainly due to risk factors was inhalation of aerosols from the infected animals. So the diagnostic test we knew was IgG antibody titer or PCR. Next is Bartella, Hensel and Quintana. It's mostly acquired from the cats, and we are doing as an indirect immunofluorescence test. Next is Brucella. Brucella mainly unpasteurized milk and infected farm animals. So here we can do serology for antibody titer, blood culture, or specific PCR. So other is non-infective endocarditis also most common, mainly lupus endocarditis, limb and sac endocarditis is there, and Beckett's disease in young male have hiatic insufficiency or recurrent oral or genital ulcers, we need to do pathology test. So how we approach the culture negative endocarditis? If blood cultures was negative, so then we go for serology, further analyzing Coxiella burnetii, Bartonella, or we can ask to prolong the incubation period of blood cultures. Usually we here 3 to 5 days, so we can prolong up to maximum 10 days. And other organs are Tiforma vipli and Brucella serologies. If serology anything positive, we can go for targeted therapy. If serologies are negative, if can go for surgical excision of valve performed. If surgical excision of valve was not performed, we can go for sequencing, 60S RNA sequencing analysis by serology only. So if serology are positive, mainly go for targeted therapy. So if surgical excision was not done, we can go for histopathology. If not done, histopathology can go, or 60S RNA sequencing also we go. Why we are mainly aiming? Because that targeted therapy will reduce the mortality in culture negative infective endocarditis, because mortality is very high in culture negative infective endocarditis compared to the culture positive infective endocarditis. So this is a American Heart Association released in 2021. So what are the indications for yearly surgery? One is patient presented with heart failure, severe heart failure, not able to medically manageable. And second is if you have any increased risk of embolic risk. One is already have secondary mitral stenosis or atrial fibrillation. Another one thing is if you had vegetations more than 50 mm, you have increased risk of embolic episodes. So we need to go for yearly surgery. And third is if we are starting empirical antibiotics because of culture negative. If patient have persistent bacteremia more than 5 days also, or is the infective endocarditis extended into the periannular valvular lesion or any fistula is forming, so that time we can go for yearly surgery. So this is a European Heart Journal released in 2022 shows the outcomes of culture negative with culture positive infective endocarditis. In this article, they analyzed totally 3,133 infective endocarditis people, out of which 2,590 was culture positive and 523 were culture negative. In this 3,000, they who are underwent for valve replacement was 1,088. Out of which 1,221 was culture positive and 229 was culture negative. His main aim was after 1 year who all had mortality. The culture negative endocarditis have high mortality compared to the culture positive infective endocarditis. After post surgical, is the mortality same or decrease? After post surgical, there is no same in mortality between both groups. So last is the usefulness of anticoagulant therapy in prevention of embolic complication in patients with acute infective endocarditis. So in this, there is a totally 150 patients, out of which 50 were went for anticoagulant therapy and 99 were for not on anticoagulant therapy, out of which 57 were experienced with embolic events. In this study, it shows there is no significant benefit between anticoagulant therapy with non-anticoagulant therapy. So back to our patient. Our patient was a culture negative infective endocarditis because of 3 cultures was not negative. So he was started an empirical antibiotics of ceftriaxone with gentamicin. So we asked microbiology for doing that 60S RNA sequencing, and also kept the blood culture for sequencing of 10 days to see if there any further growth is there. And we also involved cardiothoracic surgery to planning for yearly surgery because our patients have a vegetation of more than 30 mm around. So the learning point was approach to culture negative infective endocarditis and area indications for surgery. Thank you.
Thank you, Dr. Sakthivel. Let's ask the floor for the.
Yes, 5 months of he intermittently went to local clinic for symptomatic management, but there is no any documentation of antibiotics. But he told I will get some injection every week. We will go give one injection, but it will resolve. After that, he won't go. No childhood history, anything, no nothing. If family history also negative.
Did he have any immunological or embolic phenomenon?
No oscilloscope, no road spots.
Did he put in the Duke's criteria then?
Duke's criteria fulfill possible infective endocarditis if one major and one minor only, because in a major wise it was only echocardiography only showing that features and a clinical examination, and in minor criteria it shows fever.
Any predisposing things that we should be knowing about, whom we should be more aggressive and do the transesophageal echo, considering the
If echography itself it shows vegetation, we no need to go for a transfer.
And then see, when often we have patients with PO presentation, IE is one of the guides we consider, but we don't know PE for all of them. So, and when especially when the culture is negative and the transthoracic echo is also negative for an IE or a vegetation or a, is there some predisposing factor, or is there something that we can be like, this could be still culture negative endocarditis, or there is some predisposing factors where we will have a higher degree of suspicion to go ahead and do that, or ask them to do, because we don't routinely ask repeat patient to go ahead and do a prolonged blood culture. Right? So is there something we can know, is there a patient background, or is there some study which is showing towards some kind of patient background which will help us to think that this might be a culture negative endocarditis? This transferring echo might not be specific.
Oh, I'm not sure. Oh.
Okay, thank you. Few questions from my side. So with regard to culture negative infective endocarditis, you said that thrice it was done, it was negative. Is there a definition that you have to do so many times before you call it as culture
Yes,
negative?
so one is at least we need to do 4 cultures with first culture and last culture we have 1 hour apart, or at least we need to take every 12 hour apart 3 cultures.
Here you didn't take 4 cultures, you only took 3, no?
So emergency department will take 1. We himself we take 3 cultures.
Okay. Now the other thing is, when you say negativity, not only the number of times you do the culture, is there a waiting period that you have to wait for a certain duration before you label as culture negative? Because there can be atypical organisms. So have they defined that this is the waiting period?
In some journals I studied, they mentioned as 10 days,
10
but
days.
not surely.
Okay. Now, in our patient, he's generally otherwise okay. He presented with high-grade fever, malaise, he had loss of weight, loss of appetite, all for 5 months. And I thought you highlighted something called tattoo. Is he a IV drug abuser or anything like that? Risk factor?
No IV drug abuser, sir. We specifically accurate tattoos because if he had only once, we not suspected, but he had 3 tattoos. So we asked, and when it was the last tattoo was done, it goes for 2022.
Okay.
So that's why.
I'm just wondering, would you give more weightage to the tattoo or to the repeated injections he would be taking every week? That has a more higher risk for thing. And the other important thing is that BBVS you had done, they're all negative.
Negatives.
Yes. 2 important things which you brought out in your presentation is, you quoted a study that only 6% are truly culture negatives. That means we should be hunting for the 94%, right? In some way, because they may range from atypical organisms or some which are difficult to culture, and sometimes immunological conditions like SLE and those sort of things come, and the treatment varies in the type of antibiotic, the duration, and any other drug that is needed. Your title is it true? Why did you put that?
This culture negative is
culture
true
negative. Okay, in that sense. Okay. And anticoagulation should be, I mean, it's not useful.
No.
Is it harmful? Because when it is infective endocarditis, when it's an infective organism, is there any benefit in doing this anticoagulation?
No benefit in this recent 2014.
I want to say, is it harmful? Is it harmful?
So, side effects I didn't go through that studies.
Because this is not your usual situation of thrombus and embolus. This is you are thinking of an infection that is happening. So whether we should do anticoagulation is maybe much more harmful than. So thank you, Dr. Sakthivel. With that, we conclude. I'll just quickly summarize the 5 cases we had today. Sit down. The first was we talked about acute pyogenic meningitis, where we had a very unusual organism, and for those who are exposed to poke. The second case was the importance of lymph nodes, but I think the constitution symptoms take more weightage because you're subjecting someone to an expensive test, and whether it is really worth that versus to take the biopsy directly of that lymph node. That may be more cost effective. The third was burnt. In the burnt case, we said about how recurrent cholangitis in a person with polycystic kidney disease, you should rule out the Caroli's disease. And there would be we will have adjoining with that, a congenital hepatic fibrosis. So that is something which we learned. The fourth case, Dr. Ritesh, had a very clinical importance in the fact that not all facial puffiness and swellings are anaphylaxis. You should think of HAE. So go for the family history. The treatment is not our usual steroid and anti-allergic. Instead, the treatment is different. Unfortunately, we are in an institution which has the test to do that. But for those who don't, we still can think of based on the clinical diagnosis. And the last case of culture negative infective endocarditis, the most useful take-home point is only 6% are culture negative, 94% are still possible. But remember, that is in another series. We need to have our own series. So I would really encourage us to find out what is our yield on that. That would always be, because we want to know in our setting what would actually come. So thank you to all 5 presenters, and I hope we'll get much more exciting cases in the weeks to come. Yeah. Thank you. And I'm supposed to have the honor of giving this particular gift to the one whom I thought was best. I thought that it was the hereditary angioedema. That case was the best of the lot, because of its clinical relevance and the clinical tip of a family history and the treatment, which is different, and the atypical presentation of recurrent acute pain, recurrent abdominal pain that can come. So in that sense, it is relatively, I thought, was better than the rest. Not to say that something was not, but on that basis, I've just taken that decision. So congratulations to Dr. Ritesh.